talking today about minimally invasive techniques useful in adult spinal deformity surgery. So adult spinal deformity, it's an increasing in prevalence among older patients with multiple medical comorbidities, and it's typically defined by a Cobb angle greater than 20 degrees, an SVA greater than 5 centimeters, or a pelvic tilt greater than 20. Your goals of surgery, like other surgeries that we do, remain neural element decompression, restoration of your regional and global spinal balance, while promoting arthrodesis. And there's really a myriad of surgical options. And for Koreans, I know we all love buffets. So there really is a true buffet here. And MIS techniques can be in your armamentarium. The costs, though, of doing these kind of surgeries are the potential downsides that are related to the complication profile of ASD surgery. Open procedures, typically having long anesthetic times, large amounts of blood loss. There's been reported 40% incidence of adverse perioperative events. New neurologic deficits are not insignificant, near 10%, with a 14% revision surgery rate. And a 30-day mortality rate has also been reported almost as high as 2.4%. When you look at the complications, many of these major complications are more related to the procedural variables rather than patient variables. One specific procedure approach-related variable in terms of complications is access to the interbody space anteriorly. So an open thoracoabdominal approach, there's really a high level of postoperative pain, abdominal wall bulging, and functional disturbance. So MIS techniques include lateral lumbar interbody fusion, MIS TLIF, and mini-open type ALIF procedures that allow access to this anterior interbody space while allowing for either percutaneous segmental fixation, MIS decompression techniques, maintaining that integrity of that posterior soft tissue envelope. And that will confer the benefits of minimally invasive surgery of reduced blood loss, allowing earlier mobilization and fewer complications, and potentially a reduction of length and stay. So using these kind of techniques, there is a surgical strategy of either a circumferential type all MIS surgery, so this is using percutaneous posterior fixation, or MIS plus open posterior options, which we generally call hybrid type surgery. So the results generally show that there is statistically significant impact from these MIS techniques used in minimally invasive techniques for spinal deformity surgery, especially in the coronal plane. Some reports have also noted improvement in both segmental and regional lumbar lordosis. And generally, to have a more significant and lasting impact when combined with a posterior approach, it's generally a lot more favorable. So the ability to access that space with a comparably less risk compared to open type procedures, and the complications are like going to that same buffet and heading straight for the crab legs. So, when you look at what are the best outcomes, the best groups in terms of these clinical outcomes, generally it's when you address the sagittal plane, as we know. So addressing SVA and reducing that down to at least 3 centimeters, and then making that harmonious matching of the pelvic incidence with the lumbar lordosis, and addressing that mismatch is generally going to lead to the improvement in outcomes. So, additional data suggests that when, attempting to correct more severe sagittal deformity, the hybrid group, the hybrid type surgery where you use MIS plus an open posterior, is going to get better radiographic improvement, but that could be at the expense of a higher complication rate. So Muminelli and colleagues, they've reported a framework, decision-making framework, when to use MIS deformity surgery. And a second version shown here helps stratify these patients into 1 of 4 surgical strategies. This is useful for guidance as factors of the magnitude of that sagittal deformity. So, marked deformity is not going to be addressed by circumferential MIS procedures, whereas a hybrid approach, or if there's a fixed or severe sagittal deformity necessitating an open approach, is going to be dictated here in this framework. And this framework has been looked at clinically. Here's a 2-year follow-up study using this framework and a similar type result. The MIS techniques were successful in moderate deformity, improving quality of life measures, whereas in marked deformity there was less improvement and a higher possibility of leaving with a fixed sagittal deformity. And really, conclusions being people with severe sagittal plane deformity and an open approach is likely more preferred. Something, a newer technique, though, that has been developed is this ACR procedure. So ACR describes that minimally invasive retroperitoneal transpsoas approach, but also including full release of the ALL and allowing for better correction of the sagittal plane. And then by being able to place hyperlordotic implants, it's been reported on average about 31 degrees of improvement. So this has been looked at. Akbarani et al. Had a series, and the amount of correction was similar along the lines of PSOs. And then a more recent clinical study comparing 2 groups of patients undergoing each technique. And it's important to note that these were in a group of spinal deformity patients that had not had a prior fusion, so they weren't correcting through a prior fused segment. But they noted similar radiographic outcomes, operative times, and length of stay, although the estimated blood loss was significantly less in the ACR group. And the revision surgeries that were required were only in that PSO group here. So really, in skilled hands, I think the ACR can be allow for a similar capacity for correction compared to a PSO, with likely a more favorable, at least a similar complication profile, as well as EBL, and likely a lower reoperation rate. So in conclusion, circumferential MIS procedures are likely only effective for addressing coronal plane deformities. There's better correction of sagittal deformities with a hybrid type approach. And then severe or fixed sagittal imbalance and severe spinal pelvic malalignment require either an LLF with this ACR technique or standard open posterior fixation to perform your necessary osteotomies. Thank you very much.